Complete hypothalamic pituitary axes involve up to 3 different levels of signaling: hypothalamic hormones, anterior pituitary hormones, and hormones secreted by the gland controlled by the anterior pituitary. I find it easiest to remember the anterior pituitary hormones, so we'll start off with those. Y'all remember the mnemonic for those? It's flat pig, which stands for FSH, LH, ACTH, TSH, prolactin, and GH. This is actually a great mnemonic. It's one of my favorites because it logically groups the hormones by function as well as by acidophils and basophils. FSH, LH, ACTH, and TSH, secreted by the basophils, are all trophic hormones. That means their primary responsibility is to regulate hormones and their synthesis at the end organs. FSH and LH, the gonadotrophs, increase the synthesis of sex steroids of the gonads, which we'll talk about a lot more in repro. For now, we're just gonna forget about them. ACTH primarily increases the synthesis of cortisol at the adrenal cortex, and TSH increases the synthesis of thyroid hormone at the thyroid. Prolactin and GH, which are secreted by acidophils, don't work like that. These are not trophic hormones. Their effects go directly to the end organs. So how does the hypothalamus exert control over the anterior pituitary? For the most part, each hormone is controlled by a releasing hormone that the hypothalamus shoots down the hypophyseal portal system. Do you remember which hormone stimulates which anterior pituitary hormone? Go ahead, pause the video, and see if you can get them all. And remember, there's one odd hormone that isn't regulated like the others. The release of gonadotrophs is stimulated by gonadotrophin-releasing hormone. ACTH is controlled by corticotropin-releasing hormone. TSH is controlled by thyrotropin-releasing hormone. All that's pretty logical. The one weird thing you have to remember is that gonadotroph cells adapt really quickly to GnRH. They downregulate their receptors in response to sustained elevation of GnRH. You'll learn about this in repro, but sustained GnRH analogs are actually used to suppress sex hormones. So, at physiologic conditions, the hypothalamus has to secrete GnRH in a pulsatile fashion to properly stimulate the gonadotrophs. In keeping with the flat pig mnemonic, prolactin and GH work a little bit differently. GH is modulated not only by growth hormone releasing hormone, but also by growth hormone inhibiting hormone, otherwise known as somatostatin. Sound familiar? Yeah, it's actually the same hormone as the one that basically brings all GI activity grinding to a halt. But extremely high concentrations of somatostatin are required to inhibit the secretion of growth hormone. It's almost impossible for the gut secretion of somatostatin to influence the anterior pituitary, because by the time it reaches the brain, it's been diluted by practically the entire blood volume. The hypothalamic capillary bed, however, drains straight into the pituitary capillary bed via the portal system, ensuring minimal dilution. Isn't anatomy awesome? Finally, prolactin is tonically secreted at baseline. It does not need any hypothalamic stimulation. It does, however, require constant suppression at baseline to keep people from lactating willy-nilly. To make this even more wacky, this inhibition doesn't even occur through the hypophyseal portal system. There are actually hypothalamic neurons that travel down the pituitary stalk and use the neurotransmitter dopamine to inhibit prolactin release. Most of these undergo pretty logical feedback inhibition. For example, when cortisol levels get too high, they inhibit ACTH and CRH to prevent cortisol levels from spiking out of control. I'm not going to put these all up there because I'd kind of clutter up the diagram, but you get the idea. It's mostly pretty intuitive. This isn't quite the case for sex hormones, which get a little bit complicated in females, but again, we'll leave that to repro. But this type of feedback inhibition occurs within its own HPA axis. What I want to go over right now is the few bits of cross-regulation that occur between these otherwise totally isolated axes. These aren't very intuitive, but they're very high yield, and have some significant clinical consequences. First up, and possibly the most important, is prolactin. Prolactin inhibits GnRH, effectively shutting down the whole axis and suppressing production of sex steroids. Now this is such an important effect of increased prolactin that you're likely to see things like menstrual disturbances, decreased libido, and other sexual side effects even before you see galactorrhea, which is what everyone expects. So what are some instances in which you might see increased prolactin? Alright, you can be unoriginal and say prolactinoma, or a prolactin-secreting tumor, and yes, you'd be correct. But another reason for elevated prolactin is if dopamine isn't doing its job inhibiting prolactin properly. We call this disinhibition. So tell me, What drugs commonly cause a patient's dopamine to tank, disinhibiting prolactin? The most important one is from the psych section. It's the antipsychotic drug class. These are antidopaminergic drugs, and this is a side effect that's present in pretty much all generations of antipsychotic. It can be pretty troublesome. The final cause of elevated prolactin is actually the second of the most important cross-regulatory pathways that you need to know. As it turns out, TRH stimulates prolactin as well as TSH. And be careful before you answer this. What condition can cause elevated TRH? The answer is hypo, not hyperthyroidism, which makes sense because if thyroid hormones normally suppress TRH, then decreased T3 and T4 should cause disinhibition of TRH. But Arjun, says you, what if the hypothyroidism is caused by increased TRH? To which I say, stop being a smartass and hunting for zebras. According to Dr. Wikipedia, 999 times out of 100, the cause of weird T3 and T4 levels is going to be at the level of the thyroid gland itself. The last bit of cross-regulation I want to talk about is how GHIH, or somatostatin, also inhibits TSH, effectively causing secondary hypothyroidism. Now this one's a lot lower yield than the other two pathways, and there's only one real clinical example I can think of. Octreotide, a souped-up somatostatin analog, is sometimes used to treat an excess of growth hormone. One major side effect? You guessed it, hypothyroidism. So one more time, the cross-regulatory pathways that aren't so intuitive. Prolactin inhibits GnRH, TRH stimulates prolactin, and GHIH inhibits TSH. As with insulin, we're going to get started with the big picture of endocrine regulation, and we're going to focus in on each one, beginning with the delightfully quirky hormone of the day, prolactin. So, we all know what prolactin does, right? It's all in the name. Prolactin promotes lactation. Now, lactation takes a few different hormones to work, and the primary responsibility of prolactin is to stimulate the glands to produce milk. It does not, however, cause milk to be expressed from the breast. That's the job of oxytocin, a hormone that gets discussed a little bit more in repro. Furthermore, while prolactin does help with the development of the glands, the responsibility primarily falls to progesterone and estrogen, both of which are also at nuclear levels during pregnancy. While we're on the note of pregnancy, let me talk quickly about the complex way in which prolactin and the gonadal axis interact, because it gets a bit weirder than I described in the previous slide. Estrogen stimulates the pituitary lactotrophs, which causes prolactin levels to skyrocket, along with the sex steroids at the end of pregnancy. So what prevents mom from milking all over the place in the third trimester without any baby to feed? As it turns out, while estrogen keeps on ramping up the production of prolactin, progesterone prevents it from actually doing anything by inhibiting its effects on glandular breast tissue. When the baby's delivered, the mega doses of progesterone drop rapidly, quickly disinhibiting prolactin and resulting in rapid milk production. Estrogen drops too, but the high levels of prolactin are maintained by breastfeeding, which centrally inhibits dopamine. Like I said before, the inhibition of the hypothalamic pituitary gonadal axis is a critically important effect of prolactin. We talked about some pathologic reasons for elevated prolactin, but physiologically speaking, prolactin is the main reason that breastfeeding women do not get their menses back for quite some time after pregnancy. Any guesses as to why that might produce an evolutionary advantage? As the theory goes, if mom's breastfeeding, that means she's already expending a lot of resources on one baby, and it would take a pretty big toll on her body to add another pregnancy to the mix, so prolactin goes ahead and suppresses her menstrual cycle so she can't have another one. So we talked a lot about prolactin, which arguably has some of the least intuitive regulation in this section. Let's see if you've mastered the beast with another flash quiz. Which of the following would you expect to decrease the production of milk? Haloperidol, primary hypothyroidism, or progesterone? This is kind of a tricky one, so take your time and pause the video if you need to. And the answer is progesterone. Remember, progesterone directly inhibits the effects of prolactin on the milk glands, decreasing milk production. The other two increase secretion of prolactin. Primary hypothyroidism causes feedback disinhibition of TRH, which stimulates prolactin secretion. And haloperidol, an antipsychotic, decreases the levels of dopamine in the brain, which disinhibits the secretion of prolactin. I recommend you go back to those diagrams in the video if you're still uncomfortable with these. It can take a couple of looks to figure out. Now we're going to tackle growth hormone, our other non-trophic hormone secreted by the anterior pituitary. Like a lot of hormones, GH has some pretty wide-ranging effects. Now, call me weird, but whenever that happens, whenever a hormone seems like it affects 500 different parts of the body that have no relation to each other, I like to give the hormone a profile, or a personality if you will. It allows you to group the hormone's seemingly disparate effects into something that makes a little bit more sense. For example, I think of growth hormone as the orthopod bodybuilder. Why orthopod? Because it's all about the muscles and bones, baby! Growth hormone is sometimes thought of as an anabolic hormone, but that's mainly true for the musculoskeletal system. Its main physiologic role in childhood and adolescence is increasing linear bone growth, but in adults, it's mostly involved in bone thickening. And GH not only promotes protein synthesis, but it also directly causes the muscle fibers to hypertrophy. But in fact, GH isn't purely anabolic, because our ortho boy needs fuel for those guns. Gluconeogenesis, glycolysis, and lipolysis all provide the mobilized substrate for the protein in bone anabolism. Finally, according to our ortho bro, any good bodybuilder is always searching for the secret to maximizing workout gains. And the first thing any bodybuilder needs to know is that it isn't just about having a great workout during the day, it's also about getting a good night's sleep to jumpstart your recovery time. Growth hormone release is pulsatile, but it increases with both sleep and exercise. And it goes without saying that puberty, being a period of increased growth, is also accompanied by increased levels of growth hormone. Diet's an equally important consideration. If you're gonna get swole, bro, you gotta maximize the protein and minimize the simple sugars. Amino acids, especially arginine, stimulate GH release, and simple sugars like glucose inhibit it. So according to this slightly more formal flowchart than the one I just gave you, growth hormone gives you bulging muscles and bones of steel, and burns fat and carbs. I mean, what more could an orthopod bodybuilder want? As it turns out, there's a couple of not-so-great side effects that are very much related to the anabolic and catabolic effects of the hormone. First, while it makes all your muscles swell up, it does the same to almost all of your organs. At best, that means you get a big old tongue and a big old gut from all the growing your intestines do. At worst, you get heart failure from cardiac hypertrophy and die. Just ask Andre the Giant. Second, in an effect to mobilize glucose and lipids, growth hormone actually blocks the effects of insulin by promoting insulin resistance. It's one of two main diabetogenic hormones. Anyone remember the other? It's cortisol, and both of these can lead to the many sequelae of diabetes in the long run. Last point about GH, it does a lot on its own, but a lot of its effects, especially the anabolic ones, are mediated through a hormone called insulin-like growth factor 1, or IGF-1. And actually, IGF-1 levels are a better indicator of growth hormone levels than a random spot check of growth hormone itself. Can you guess why? Hint, it's a lot like GnRH. The reason is because GH, just like GnRH, is secreted in a pulsatile manner. So if you took a random sample, you could be taking a sample at a peak, a trough, anywhere in the middle. IGF-1 is a lot more consistent. Now let's take a brief diversion into the land of appetite and thirst regulation. I know, it's a bit weird going straight from pituitary hormones to this, but bear with me. This is sort of related to growth hormone. Kinda. Tangentially. We've talked a lot about regulating the metabolism of the nutrients the body already has. Now we're going to talk about how the body regulates the intake of food. Appetite regulation is majorly complex and historically not tested on step 1, but there's a few hormones we've seen tested recently, so we'll go over them. The hormones are ghrelin, the hunger hormone, leptin, the satiety hormone, and the endocannabinoids, which I'll effectively refer to as the munchies hormones. Ghrelin is secreted by the cells in the stomach when it's empty, so I always remember ghrelin as growlin', like when your tummy's growling, on account of hungry. Leptin, on the other hand, is secreted by fat cells when they're all full of fat. Both regulate the body's drive to eat, so think back to neurology. What target cells do they act on to modulate your hunger? Both of them act on the hypothalamus. Ghrelin specifically increases activity in the lateral hypothalamic nuclei, and leptin specifically increases activity in the ventromedial hypothalamic nuclei. One good mnemonic to tell them apart: activity in the lateral hypothalamus makes you hungrier, eventually making you grow laterally. Oh, and if you need any more confirmation that the med school lifestyle is conspiring to make you fat and out of shape, sleep deprivation hits you with the double whammy of increasing ghrelin and decreasing leptin. Just to see if you were paying attention, what's the other hormone that we literally just talked about that's also decreased by sleep deprivation? It's growth hormone. So not only does a lack of sleep make you eat more, it also makes you less likely to build muscle and more likely to put on fat. So take care of yourself, kids. It's going to be a long ride. Last bit of info about ghrelin and leptin: abnormalities in both are implicated in obesity disorders. Prader-Willi syndrome, the disorder known for creating hyperphagic, mentally retarded kids with micropenises, is associated with increased ghrelin. Similarly, many congenitally obese individuals have disordered leptin, making it difficult for them to feel truly full. Finally, everyone's favorite hormone that I've been conspicuously avoiding, the endocannabinoids. Even more so than the other two, endocannabinoids are way more complex than I'm going to deal with here, so I'll limit my discussion to what's step 1 relevant, and a little bit to what's funny. Endocannabinoids, as you might imagine, stimulate appetite, but specifically cause you to experience fatty foods as extremely pleasurable, as I'm sure some of you future doctors know. If this picture gives you the irresistible urge to go on a midnight run for cheese fries, you might be high.